dealing with pain management as well as the side of, addiction and abuse and dependence and all that sort of stuff. So just going to kind of give you guys an overview. I was also at a conference a year or two ago now where it was actually geared towards law enforcement side and what they deal with. So it was a really unique perspective. Myself, as a healthcare professional, we think of it more from a chronic disease, how do we treat it, how do we manage it, versus the law enforcement side dealing with some of the ramifications that we see out in the community. So that was a really eye-opening thing for me as far as, it really truly does impact everybody from law enforcement, healthcare, schools, kids, with parents that are addicted, taxpayers, you think of health insurance, you think of all that stuff. It truly does matter, and anything we can do to reduce the number of people who are addicted to opioids and other medications, I think is a valuable thing to do. So, just a little, I'm sure you guys see blurbs in the news. I had one come up just this morning on my Facebook feed about some sort of pink powder or something that was going around, I think, in bigger cities. But what's happening from the DEA perspective is you're getting a lot of basically these impromptu factories, and they're propping up in China, they're propping up in Mexico, and they're actually creating new compounds that work like opioids, but they, aren't as detectable, or they're super potent, or they're, all these different things, and they're putting them in basically with the street drugs. And so what happens is you get an ultra potent drug, and it goes out through the distribution channel of illegal drugs and ultimately gets to the end user. And what happens is you'll see 10, 20, 30, 40, 50 people, depending on the size of the community, get this bad batch of the drug or this excessively high dose of the drug, and you'll get that many people coming into the emergency department, a rash of deaths, and that type of thing. So that's really, from the law enforcement side of things, that was, what I gathered from them. That's their focus, is to really try to stop that supply from coming in. But, like they said, as long as there's such a demand for these drugs and people are addicted to opioids, that's a huge challenge, because where there's demand, there's going to be money and people trying to profit off of that. So this was an example in Moorhead. You can see the name of the drug was, it didn't even have a chemical name, or it didn't even have a regular name, 47,700. So this was just basically a drug that was created in China that hasn't been tested on anybody, probably hasn't been really tested on animals or anything. So ended up, killing this individual, unfortunately. Certainly we've seen report stories in Detroit Lakes as well. And we got a small group, so feel free to interject, ask questions, if something doesn't make sense as we're going here too. So some of the statistics I pulled away from this opioid summit. So 4 out of 5 patients that are currently using heroin started with prescription pills. And some of the addiction specialists said there is a really big jump and a really difficult decision that people go through when they first go from prescription meds, where they can, try to work the system, get as many as they can from different prescribers, and doctor jumping, pharmacy jumping, that type of thing. There is a really difficult decision for them to go to injectable, but as you can see, 4 out of 5 heroin users started with pills. So, what that tells me to speak to you guys in the community is, get rid of that stuff. If you've had an operation, surgery, if you've got hanging out, kids, grandkids, whoever, that's really how they get started is through pills. And obviously many of those are through legitimate prescription pills as well, where they had an injury or something and ended up becoming addicted and that sort of thing too. So, but yeah, from the medical community side of things, I mean, it's a pretty harsh statistic to think that we caused a lot of problems. And I mean, I can remember in school, so I graduated in 2009 from pharmacy school, so about 10 years ago or so. And I can remember the emphasis on treating and managing pain. And that is a very, very important thing to do. But, it comes at the expense of risks of medications. And obviously we're figuring out that, there are some pretty big risks to using some of these medications long term. And some of the terms I'll talk about up ahead, addiction, dependence, tolerance, all those sort of things can be kind of a vicious cycle. So you can see the numbers. We had a presenter from Twin Cities area, Hennepin County. So 2008, they had 8 deaths, and I think this was September time frame. They already had 66. So from 2008 to 2016, 8 years, I mean, that's a 10-fold increase, basically, in the number of deaths that are pretty close. Again, keeping medications locked up, secured, 66% of pain medications abusers, users, get those meds from family, friends, relatives. So a term I'll define a little bit better coming up ahead here, but what do we do with people who are addicted to opioids? I mean, that's really an ethical dilemma, it's a moral dilemma, it's a cost dilemma. What is best to do with people who are addicted to opioids? And they definitely made the argument, and I do think it makes a lot of sense, to really try to get them into recovery, try to get them into remission, and from specifically a societal cost perspective, that is the least expensive way to try to help these patients, and is the best way to try to get them off of drugs. Because what happens is addicts go into jail. They're in there for months, weeks, whatever, and they abstain, they go off the drugs, and when they come out of jail, they end up going back on the same dose that they were taking, and then they overdose. Because the term tolerance, which I'll define coming up here a little bit more, but you become tolerant to these drugs. So that means you can continually kind of slowly escalate the dose as long as you slowly do it, and your body just gets used to it. So I've seen patients up on 2,000 milligrams of morphine per day. The usual starting dose is 5 to 15. So, I mean, that's a 100-fold increase, basically. 100-fold plus, 200, 300-fold plus escalation in dose, and that's because of tolerance. You just get used to it, you bump up the dose, you get used to it, you bump up the dose, and keep going like that. So that tolerance disappears over time. So if you abstain and stop taking drugs 2, 4 weeks, 6 weeks, 8 weeks, you're going to lose that tolerance. People get out of jail, they go to the street, they get the drugs that they were used to taking, they take the usual dose that they were taking, and they end up right back in the emergency room, hospital, or they die from an overdose. So it's a vicious cycle for sure, and obviously that's cost to everybody as well. Talking about the expense of hospital stays and emergency room visits and all that stuff too. So big challenges, which is why drug courts have grown in popularity, where it's an ultimatum. Either you're going to go to jail or you're going to go to some treatment. We're going to give you opportunities to try to fix this, so we don't continuously go into this cycle. So
I have a question.
Yeah.
That little last statistic there, less than 5% of people who are in treatment have been referred by physicians.
yeah,
So is it really hard to tell when someone gets to the point where they're addicted? Like, from
exactly.
a doctor's standpoint.
And this was just relaying the information that medical schools, medical community does a really poor job of treating or of teaching addiction and all that sort of stuff. And through pharmacy school, I don't remember being taught much at all. Maybe a lecture or two about addiction, and that was it.
Wasn't that much?
Yeah, and medical school, I've talked to PAs, nurse practitioners, med students, med school, years ago, it just isn't high on the radar for
So
sure.
then is that just part of the piece? It's just so hard to tell when someone is addicted to that?
It
'Cause
really,
if physicians
Yeah.
have a hard time recognizing it, and then you as family members, you have someone in your family, and it's, I'm sure, even more.
exactly. It is very hard to recognize. Obviously, the more you're with somebody, I think of a 15-minute doctor visit, and
Yes, right.
Can you get the whole picture
Right.
in that time frame? Especially
Well, maybe
if
if
you're
a
trying to do
family
other things,
Right.
take care of their blood pressure or anything else that might be going on too. So
then
yeah,
a
that
big
was
piece
just
is maybe educating people in the public about how to recognize the signs.
exactly. So I definitely will talk about the opioids a little bit. Kind of signs and symptoms. I've got a short little video too of what you might see in somebody who has overdosed too. Yeah.
So you said you've seen scripts for like 2,000 milligrams.
Yeah, I've seen patients on that much. Yeah.
Well, as a pharmacist, so when you see like a script, because now we're having to go through all the check their med list and
Yep.
report any misuse.
Yep.
Which is kind of new for us. Like now we have to do it. So if you see that coming through, do you guys go back to the doctor and be like, hey?
Yeah, absolutely.
Like-
I mean, what's going on?
And then are they very?
Yeah.
Sometimes I feel like they're not responsive to us. Like we get them come and we know they're snowed by their pain pills.
Yep.
And so we're telling them, and it's like, whatever, he just had a knee replaced. Well, no, like he is snowed. Like
Yeah.
this is. So are they more
Yeah,
responsive to that as a pharmacist?
It's, you're dealing with people. So some are really good.
Sure.
Some aren't. Also that relationship matters with the physician. If you know a physician really well, and as a pharmacist, if I don't speak up too much on things, and all of a sudden I am, it's just like, oh yeah, maybe I should think about this again and that sort of thing. So yeah, it's one of those things. I think if you're put into that situation where you see something uncomfortable, that type of thing, I would definitely get another opinion from a pharmacist, from a nurse, something like that too, just to kind of bounce it off and say, maybe I don't know meds the greatest, but is this right? And oftentimes I think if a provider hears it from two people, that's kind of a red flag to them as well. Just like, okay, we got to figure something out. And doses that high, it certainly could be an error, which we obviously should be questioning. But yeah, that particular patient, they were being seen in a pain clinic, and yeah, they had just escalated over time to that dose, and yeah, it was a bad situation to say the least. But yeah, you mentioned would they be laying on the street and passed out, knocked out from all those drugs? That's that tolerance. So if you go up there slowly, yeah, you can get to those crazy high doses and be a somewhat functioning individual. So that's kind of that body's adaptation, and all drugs are not like that. Where you escalate doses, say on a certain blood pressure medication, you might not get tolerant to that effect. So you're gonna
I take a thyroid And my thyroid is, and I know when it's off kilter when.
Yeah, so that's a good example there where your body doesn't,
When my eyes go shut.
yeah, you don't have to continue to escalate that dose, your body gets used to that dose, so, yeah, good question for sure. One other important point I wanted to make on this was the cost, like I said, where there's demand, where there's money to be made, and this is what law enforcement was relaying. There's going to be money rolling in. So 1 kilogram of heroin, that's just 2 pounds of heroin, $80,000, that's approximate street value.
Is this back then or is it now?
Yeah, this was just a couple years ago, this data is from, yep. 1 kilogram of fentanyl, so I'll talk about potency coming up. Fentanyl is ultra potent, so a tiny bit of it gives you the same effect as a larger amount of heroin. So 1 kilogram of fentanyl, diced down, divvied up, and sent through the chain, it's approximately 1.2 to 1.8 million. So just 2.2 pounds of that amount.
So they were saying like
Worth that
fentanyl's a hard, we were having a shortage of fentanyl.
Yeah.
Is that because they're trying to get it off the streets, or
So, yep. So there's.
manufacturers stop making it, or what?
So the other unique thing about heroin is it's produced from the plant. And so heroin supply depends upon crops down in Central America and all that sort of stuff where a lot of the heroin comes through. Now fentanyl is chemically produced in a lab. So that's for these drug creators, manufacturers, illegitimate manufacturers. That's the lure of fentanyl, is that you can create this in a lab. It doesn't depend upon weather conditions. It doesn't depend upon all this sort of stuff. But the challenge with fentanyl is it's super potent. And when you hear patients overdosing, a lot of times you'll hear heroin laced with fentanyl. Well, it's a little bit of heroin, and they've got some fentanyl in there, so they can kind of, spread out their heroin supply if they don't have a lot of heroin. So you still get, the same opioid effects. But, you will hear from addicts and stuff that fentanyl is a little shorter acting. It doesn't last as long, and it does maybe provide them with a little different feeling and that type of thing too. So, but, if you're trafficking drugs and trying to make money, this is, a good route to go as far as transporting and all that sort of stuff. So,
Well, the end user doesn't know
yeah,
what's actually in it.
exactly.
And they don't, it
Yeah.
all looks the same, so they're not gonna know if there's fentanyl in
Yep.
it or it's pure heroin or.
Yeah, and so when you go to the pharmacy, you pick up a medication, you've got to trust that that medication is right. That you're getting the exact dose, that the manufacturer produced it correctly, that somebody's watching that manufacturer to make sure that, other things aren't getting in there and it's the correct dose. You're trusting that the, distributor sending it to the pharmacy isn't doing anything inappropriate with it. And then ultimately, you're trusting that the pharmacist and the team in there is dispensing that correctly. So there's lots of checks and balances within there to try to prevent problems. Whereas the illicit drug market use, who are you trusting there? So
I
yeah,
have a question.
Yep.
Is there anything being done at the level, like hospital level? I had major surgery in 2002. I had a cervical fusion.
Mhm.
And they ask all kinds of questions before you go into surgery. Not once do they ask, what is your pain tolerance? Never.
Yeah.
So I come out of surgery and, they open you up in the front to do the cervical fusion. You're swollen as swollen could be. And I was given, I think it was Oxy, I'm not sure. And
Sure.
the pills are so big you can't even swallow them.
Yep.
And I said, to me, I think it hurts worse to swallow this pill than if I just
Yeah.
suffer through this. And the nurse told me, oh, you have to keep on top of the pain. Well, especially when you're an adult, you probably, at my age, know what your pain tolerance level is. And my husband, the comedian, says she doesn't really have any feelings. she probably can. But at any rate,
Yeah.
I chose not to take those.
Okay.
And I said, can I just have take a high level of ibuprofen, which I took 800 milligrams. I never needed those pills.
Yeah.
And to me, that's a huge part of the problem. They do not assess the patient as to what their pain tolerance level might be at the get-go. Wouldn't it make sense to start way back there?
Yeah, and from the healthcare side of things, it is, it's really hard because everybody's different,
Right.
you know, and depending on the surgery and how much pain's anticipated and all that sort of stuff, it's so hard to predict. You know, who's going to be in more pain, who's going to be in less pain, that type of thing. There is, you know, getting to be lots of genetic testing and different things like that as far as looking at meds and, you know, who might respond better and things like that. Isn't really mainstream yet at this point, but we're definitely learning more and more about that. With that said, there is a huge push because dependence and tolerance and all these things start to develop after a couple of weeks of use usually. There is a huge push to really limit the amount that we're giving post-discharge after you're sent home from the hospital from whatever surgery or whatever you had. Because there's a lot of evidence saying that, I saw a study that showed whatever the patient was given, they used approximately 2/3 of it because that's how much kind of pain they expected that they should be in, or that's what they expected that everybody else goes through. So whether they gave them 150 tablets or they gave them 10, they found that the majority of patients used approximately 2/3 of that amount for their pain. So again, it didn't really matter how much they gave them. They just were thinking, yeah, I better stay on top of this and that type of thing. So the
People are
pendulum,
tougher than we give them credit for.
the pendulum is definitely swinging back to, like, yeah, we don't want to create any new problems. We'd probably rather lean on the side of patients suffering a little bit more in the short term than creating this really bad long-term problem.
Well, I think we got into a
So-
swing where patients would come in and nobody wanted to be in pain.
Yep.
And so you're like, well, how can, I want to stop the pain. And so then the providers were giving him whatever. Then they sent him to me and they're like, oh, my back hurts. I'm 75, I've got like 3 out of 10 back pain. I'm like, good for you, you are 75. 3 out of 10 is not bad.
Exactly.
And they look at me like I'm crazy. I'm like, well, where in the Bible does it say thou shalt not have pain?
Yeah.
Yeah.
So I think if we can learn that, pain is not bad, it's
Yeah.
just,
How do you
Right.
treat it?
Yeah.
and
we can
manage
do
it?
other things than just a pain pill.
Right.
So, I think that helps if we can educate.
Well, nurses, I think, have switched to like educating patients, like, for the first 24 hours after surgery, you need to stay on pain regimen. Then let's try ibuprofen and Tylenol. Let's get you off of those narcotics because they don't make you feel great. They have side effects. I mean, we've been even on OB floors and stuff. A lot of the women aren't getting anything anymore. It's Tylenol and ibuprofen. That's it.
Right, yeah.
So, and
But
yeah, like you said, I remember being taught in school, if they have pain, basically you believe them, and, what do you do for pain? Well, you give them, more pills and you
That's it.
ratchet up the
Right.
dose. So,
Mhm.
yeah, that pendulum's definitely swinging back. Yeah.
Well, many of the over-the-counter medication is based on adult or child. My husband, who weighs 120 pounds more than I, if I take the same cold medicine he does, I'm a zombie.
Yeah.
Is prescription medication the same way? Is it basically just adult and child, or is it more based on weight? Or I like the idea of asking about tolerance.
It really depends upon the medication. Like I talked about genetic testing a little bit and stuff. We are learning that, so much about that, where some people metabolize meds really quick, others metabolize meds really slowly. And depending upon the drug, there's different pathways that these drugs are broken down. And so we're learning a lot, but you know, it's still kind of an art a little bit as far as what dose is appropriate, what's gonna work, for who. And really our best guide is usually past history. You know, what have you tried, what worked for you, did you have any side effects on that dose and that sort of thing, so.
And all you can do is take their word for it.
Yeah,
And that's how doctors get fooled. is
Yeah.
People they're smart at working it. So.
Yep. Yep.
I just feel there should be an assessment when you go in for surgery too, though. They ask a million questions. Like in my case, I bet they asked me 40 times throughout this
Yeah.
process if there's anybody abusive in my household. Because I suppose they were concerned that I would get hurt
Yep.
after the surgery or whatever. They could have taken 1/5 of that time and asked about pain tolerance.
The problem is when you ask questions like that, the scale is so random, because somebody will tell me they're 10 out of 10 pain and they'll be talking to me. 10 out of 10 pain should be unconscious. So even if I give a scale and ask somebody, rate your pain or what you think your tolerance is, and where do you think you need medication, somebody will tell me 3, somebody will tell me 8. And you come out of surgery and if I ask a question, how's your pain, and you're crying, I'm going to give you pain meds.
Oh, and I agree.
I mean, but
Where I
so
think it
where
should
you get
start
that,
is as a whole, like during your life and a child, you couldn't do this, but typically do you take ibuprofen for pain management? You know, how's pain management been your whole life? And I think you've taken ibuprofen 12 times in my whole life. I mean, everybody's different, and therefore dosages are different, and
Yeah.
it's just a matter of asking.
Exactly. It's really hard when you're talking about you know, subjective things there. So law enforcement, DEA, you know, their focus is definitely on the supply side, where they want to, you know, take care of gangs, drug dealers, things, you know, folks that are bringing these drugs in, rather than, you know, trying to, you know, lock up addicts for 30 years, you know, for doing drugs, and the end user. So, because, yeah, you could jail all the addicts and we would need to build jails all over the place. So, that's not going to work as far as from their perspective. Mexico, China, now online sales, that's happening. What they call the dark web. I'm not crazy an expert at that, but basically they can encrypt payments and all sorts of different stuff that way. This is just something I found, just reported last week. So 120 pounds of fentanyl, so about 50 kilograms, I suppose, or so. And this was an online purchase, basically trying to transport it from China, I believe, found in Nebraska. So, I wanted to make the point that a drug overdose is not a drug overdose. They're all different. So, you know, if you've got an opioid overdose, you know, oxycodone, heroin, fentanyl, all those are the same. They're going to present, by and large, the same way. Now, methamphetamine is 100% different. So, I'll talk about opioids and the side effects in a little bit here, but methamphetamine, cocaine, those are two examples of stimulants. I would say methamphetamine, in talking to law enforcement around here, it's methamphetamine and opioids. Those are the two big ones. So that methamphetamine overdose, what you might see in a patient like that, you know, they are basically ramped up. You know, blood pressure's way up, breathing fast, euphoria, really chatty, you know, that type of thing. You know, those are the people I think that, you know, when police are trying to arrest them or something, you know, they're banging out windows and that type of thing. They're really amped up, hyped up, which is polar opposite from an opioid overdose. Let's see if I have that. So opioid side effects. What you would look for in the community is basically somebody essentially passed out. Respiratory rate or breathing is probably the #1 sign. Somebody that, you know, you might see laying on the ground or something. So if you see them only taking, a breath every 10 seconds or something like that, that might be a good indication of an opioid overdose. So what the drugs do is they slow the lungs down and basically stop you from breathing. And over time, if you don't breathe, you don't get oxygen to all your tissues. And obviously the heart and the brain are kind of the last two where the body tries to divert that oxygen, what little you have remaining. But if you get too high of a dose, too big of a dose, it can ultimately stop breathing altogether and kill somebody. As far as just kind of general side effects, constipation, confusion, and sedation. So again, methamphetamine overdose compared to an opioid overdose, totally different ballgame as far as what you're going to see in somebody. So one other unique thing with opioids that's kind of a clinical sign that we see is their pupils are really, really tiny. So really pinpoint pupils. That's kind of a unique characteristic of an opioid overdose as well. So those terms I wanted to talk about, so potency, so that basically means, so I use that fentanyl heroin example, so a tiny bit of fentanyl can give the same effect as a significantly higher amount of heroin, because fentanyl is a more potent drug. Now, if we're talking about prescription drugs, so oxycodone, morphine, those are kind of commonly used in hospice and short-term pain relief and things like that. We've got these comparable charts that we can look and see what doses are approximate to one another. But fentanyl, like I said, is ultra potent compared to other medications. Now, tolerance, that's that effect I mentioned a couple times where you can continually escalate the dose over time and the body just simply adapts to that. So somebody that took 200 milligrams of morphine at one time, if you've never been on opioids, not currently taking them, that could potentially kill you. Somebody that's on 200 milligrams of morphine every day, their body's adapted to it, and you don't see the suppression in the breathing that you generally see in somebody that hasn't had it before. So that's kind of that tolerance effect. And then I mentioned that example with prison, where that tolerance goes away as patients stop using the drug. So you can't go right back up to the dose you were on 2 weeks, 4 weeks ago, or it is potentially lethal, where it could
Exactly,
kill
they
you.
get out and all of a sudden they go back, think that they could take.
Use the same dose. Exactly. So if they stop taking it for a while, no matter what the setting is, treatment too. When
And even a
patients
couple
are-
weeks is enough for that.
I would say 2 to 4 weeks, that tolerance really starts to go away. So jail I mentioned and treatment programs are a huge, huge risk after they get out and get out into the community. And that's in my mind and reading and seeing, that's a huge gap. Where
You're going
where
from-
people are a huge
You have
risk.
no access here
Right,
at all,
and
and
people
you're
watch-
out on your own.
And people watching you and support, and you've
Mhm.
got everything right there helping you get clean. And then you go out into the community, and your drug dealer's looking to make a little bit of money, and they come knocking at your door, hassling you, threatening you, whatever. And now all of a sudden, what do? Well, go back, get the same dose that you were getting before, end up in the ER, hospital, and here we go again. So, brutal cycle for sure. So addiction and dependence are kind of two terms that get interchanged. So addiction, it really involves the lack of, patients just don't recognize consequences from what they're doing. And, the awful picture, I don't know if you guys saw this, it was a couple of years ago, but basically it was a couple of parents who were addicted and kid in the back seat. So that is, you know, a true example of addiction where there's zero focus on anything but getting that drug. That is the sole focus, and that they've actually shown in studies that the brain actually changes and adapts the reward center in some of these people, and yeah, it's a brutal thing for sure. Yeah, one of the really eye-opening things for me, so relapse with opioids is really, really common, which stinks. I mean, it's terrible. And to actually really start to show lower risk of relapse, you've got to get 12 to 18 months out from them stopping using. That is a long, long time for somebody to not restart using before those relapse rates start to go down. So, yeah, it's a brutal thing for sure. And we do use some medications that work similar to opioids. You know, some people think it's controversial, others don't, because some of these drugs have activity similar to opioids. Personally, if it was, my family member, I would be fine with them using one of these replacements to try to get them to a stable state where, maybe they can go to work still, they can get their life in order and slowly start to recover from their addiction, and then, maybe the longer term goal of getting off altogether. They've shown a little bit better data with, kind of that model maybe than going cold turkey. Now, there's definitely cases, instances, and there's definitely institutions that believe that, cold turkey and not doing any of these medications to kind of help ease that is the only way to go. So there is definitely some controversy out there, and you will hear two sides of the story on that too. So, dependence. So, dependence definitely different from addiction. So all people who are addicted will have dependence on the drug, but pretty much anybody that's on opioids for 2-4 weeks plus, their body will get a physiological dependence on that medication. And simply what that means is when you stop taking it, you'll very likely have withdrawal symptoms. Now, if you're on a super, super tiny dose, maybe there's potential you wouldn't. But usually anybody on these medications for 2 weeks, 4 weeks plus, you're going to have some withdrawal symptoms upon stopping. And yeah.
So I get asked a ton, am I going to get addicted to this? Like after knees, especially knees, because knees are painful.
Mm-hmm.
And I'm always like, well, have you been addicted before? Do you have addictive personalities? But should I keep like dependence in mind? Because if they're on it, some 2 to 4 weeks is kind of the norm.
Right, exactly.
Should
which
we
is why we try to
forewarn
limit.
them that, addiction probably not, but you may notice when you stop taking it that your body will show some signs, and that's okay?
So, ideally, the ideal goal in that type of recovery patient is, you probably should be taking less, on day 5 than on day 2.
Okay.
So, working with the provider who's ever done the surgery, and you reporting back to them saying, look, they're still taking
Right, like
5,
every 4.
6.
I'm usually like, you should only be taking it when you come to see me.
Yeah.
By week 3, really, I should be the worst cause of your pain.
Exactly.
So when they're coming,
Yeah.
I'm taking every 4 hours. I'm like, you really probably should just try not.
Yeah, exactly. So, managing it, doing ice, doing different things, all that sort of stuff is definitely an important thing. And, the shorter you can limit that time frame that they take it, I think the less likely that they're probably going to have withdrawal symptoms when they do eventually cut out. So, and, withdrawal symptoms can be overcome. They're generally, with opioids, they're generally not life-threatening. So that is a nice thing about withdrawal. However, if you've got patients that are unstable, at risk for suicide, mental health concerns, things like that, and all of a sudden they've got anxiety and other things going on from their opioid withdrawal, there's definitely been scenarios where that's put somebody over the edge. So definitely kind of keep that in mind as far as withdrawal goes as well. I did want to get to withdrawal here. Yeah, so these are some of the symptoms of withdrawal, and in patients that have been on opioids for a really long time, years and years and years, this is what keeps them on the drug, because they stop taking, or maybe they want to, and they're going to experience significant symptoms. Think of the worst stomach flu you've had. Think of anxiety, can't sleep, shaking, sweating, all sorts of nasty withdrawal effects when you stop taking opioids. And, it's easy to think, well, you can probably just get through them or whatever, but, if you've got a pill sitting right beside you or a drug sitting right beside you that can take all this away, within 15 minutes, it's a really, really hard thing.
Can these be minimized by a long-term tapering?
Yeah, exactly, and that's what I worked with patients who are on chronic opioids for pain long term. We definitely try to go slow, try to prolong that tapering down period as much as we can, because that definitely blunts some of the withdrawal symptoms. There's also some other medications we can use to maybe try to help manage some of those symptoms in the short term, which we used with some patients, and some patients we didn't. But yeah, really that long, slow tapering down process is usually the best. I've had one or two patients where they just want to go through it and they want to try to get done with it and just be off altogether. But I would say that's probably the exception more so than the rule. So, no, good question. Yeah, we've got a few minutes left here. Any other questions, burning questions you guys can think of?
You see most of the risk, societal risk, coming out of the healthcare situation that starts out normal pain treatment by supposedly stable, normal patients coming in,
Yeah.
or more of a problem with individuals that are looking for an answer to escape society's problems, and they think this may be an answer.
So, like I mentioned with the injection thing, and patients going to injecting themselves with heroin, very, very rare is that ever a situation where somebody's just going to be like, I'm just going to start using heroin to escape my problems and inject myself. It just does not happen very often. Like I said, 4 out of 5 start with pills, and they get dependent upon opioids. And if they get cut off, if they're abusing, if they're taking way more than they should, what's going to happen is the provider, nurse practitioner, doctor, who's ever working with them, is going to say, I'm not comfortable with this. I'm not comfortable with giving you anymore. And then they're in a situation where they're going to go through withdrawal, and they've kind of got to make a decision at that time, what they're going to do. Am I going to go try to steal other opioids from somebody? Am I going to go to another doctor? Am I, what am I going to do?
I guess my question had to do with what you touched on. What's the driving factor at that start?
So initially,
where they go from using things as prescribed in a manner in which it was intended to the abuse, the overtaking. What's the driving factor in there?
Yeah. So initially, and we have found a lot with genetics too in this, that some people are more predisposed.
Okay.
And initially, they get that euphoria where they feel good, you know, and they feel great and, you know, all this sort of stuff. And
At what dose though? Either are they being prescribed that dose for normal stuff, or is it just, is there something that says if one takes away the pain, you know, maybe two will take away the pain and I'll feel good?
Yeah,
Or is it-
and some patients are definitely more at risk for taking more and abusing things. And you know, usually what we try to look at is addiction history. Have you had trouble with alcohol? Have you had trouble with smoking? You may be a little bit more predisposed to having an addiction and developing that. But yeah, there can be an initial euphoria and kind of feel good from the medication, and that kind of keeps people going. And then they continually escalate that doses to keep trying to get that feeling. And over time now, even with that escalation, now you start to get that dependence, and then when you try to come off, you get the withdrawal symptoms. So, hopefully I'm kind of answering your question, but as you initially start, it's more for kind of the feeling good and euphoria and that type of thing.
Well, I grew up in the '60s, you know, and and what society went through a whole period, you know, different drugs, different reasons, many of the same issues. Started with different drugs, ended up with the heroin and so you know, so it's nothing new. It's just the scope. You know, from my perspective, as far as what I see as a societal one. But
Did they know, is there like a percentage of how many people come to the abuse through just getting prescribed, you know, for a pain, a legitimate pain, as to people who are coming at it because they have other addictions or other issues in their lives and they're just finding sources for it?
Yeah, I don't know the exact percentages of how many started based upon legitimate pain use. I would definitely say it's overwhelmingly over 50% for sure. But you know, I think about, you know, myself obviously with kids and stuff. The younger they start, the younger they try things, the more susceptible, the more likely they are to develop a problem long term. And I don't know if it's, you know, I don't think we know for sure if it's with brain development or what exactly that is, but the younger somebody starts with alcohol, with any drug, the more and more likely it is longer term down the road that we're going to have a lifelong or a longer term problem with addiction. So, I did, you know, want to mention another really controversial thing that you'll see in bigger cities is syringe exchange program for heroin users, where basically heroin users are given syringes, clean syringes for free, essentially. You know, huge controversy surrounding that. There's two sides of the debate on that. You know, if you understand addiction, and I think, you know, at least in my discussions with physicians that treat addiction every day, and in hearing it from a few patients who have been addicted, they could care less whether they have a clean or a dirty needle. They're going to use the drug regardless. And, you know, again, it's kind of that, you know, are we encouraging that behavior? By doing that, you know, my feeling is not. They're probably going to find whatever syringe they've got and do it anyway. The flip side of it, you know, is thinking we're probably going to save a lot of money in future healthcare costs by giving them clean needles. It's a cheaper, cost-effective way of preventing HIV and hepatitis, which costs hundreds and hundreds of thousands of dollars of treatment management medication over a lifetime. So, yeah, very, very challenging ethical, moral dilemma on that type of thing. But I would say it's definitely becoming more and more common with syringe exchange programs within bigger cities for sure, but really a tough one to kind of get your head around too. So you just want
We're
to
not
point that
like
out.
that here yet. I hope not.
Yeah, I don't believe there's any syringe exchange program that I'm aware of.
We have one, harm reduction
Oh,
in
sure.
White Earth has one syringe exchange program.
Detroit Lakes, I don't think there's
I don't
anything
think
in
so
town
either.
here. So, thanks for mentioning it.
But like you
Yeah.
say up there, is that the only place around here that has, and then they also have that, my daughter-in-law works up there, so then she helps the drugs coming on, you know. And is that the only place around here that has, does Becker County, other way, I mean, any place here in DL? Does anybody know?
Yeah, I'm not sure on the, are you talking about medication kind of assisted
Yeah,
treatment
come off
programs?
the, yeah.
Yeah, I know Fargo Moorhead has,
That's the
pretty
closest one
pretty
to
extensive
Lakeway.
programs, yeah.
I think
there was-
that's that whole mental health that we lack
Yeah.
here.
Yeah.
Like, I think that'd be part of it, like, mental health, drug addiction,
It's all
that's
together.
that's a bubble that somehow we've recognized, but I don't think there's a lot of,
Right.
Info on it,
right?
around
Or
for the
like
bubble.
how,
Yeah.
and I work with someone who works up in White Earth, that's what she does is that thing, and I'm
That's
like,
what-
tell me more about it.
That's my
And I can
daughter
see where
does.
some people be like, that's terrible, but then really
Yeah.
when you think about it, it's
Yeah.
not terrible.
Yeah.
You know, you are helping these people who are addicted to something, and they're not gonna change unless someone
Yeah.
says, you know what, I'm not gonna take it away, but and then once you start, just to see
And
them
then, yeah,
change.
from the law enforcement side, you know, it's like, well, hopefully that's less robberies, less
Yeah,
thefts, you know,
yeah.
people trying to get money and, you know, steal things from you. So it's a, yeah,
It's a circle, yeah.
tough.
All the things that they're trying to come up with now, I mean, even syringe programs, I mean, you might not like it, or you might, you know, have different opinions, naloxone, medication assisted treatment, like all of those are things that are maybe controversial, but they're just trying something. I mean, we've gotten into this problem and it's such a crisis, like you said, and they're just really trying to find, you know, what's gonna work, what's gonna help. Right.
I treat so many abscess wounds. You're like, oh, how'd you get that? Oh, I don't know, really? Oh, I've had them here, 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 here. I mean, you see them all the time. You know exactly where they got that. And it's like, could you just be clean? Like, are you really? You just want to be like, you are dumb. But you can't.
Right? Yeah.
But if you could say, you know what, here, go to this place next time, at least get a clean one. Like, I don't think that's feeding the problem. It's helping at least get them out of my office because they have this abscess in their arm.
You're preventing symptoms.
Yeah.
That's just
Because
like
of
taking
the
a clean
addiction.
syringe, like he says, having a clean syringe instead of, you know.
Yeah, and maybe over time they'll see, maybe that will spark something that will lead to a more permanent solution.
So a few take homes, you know, I definitely mentioned to people out in the community, if you've got stuff in your medicine cabinet, you know, things like that you're not using. You know, it's from an alt surgery, you know, it's an opioid or drug that can be stolen. Yeah, I definitely say that.
here in Becker County?
Yeah, so sheriff's office.
Yep, right over here across the street.
Essentia in the pharmacy, in the clinic pharmacy, right when you walk in the main clinic doors to the left, there's a blue bin in there. You can just ask them at the desk. I know they got one in there too, or at least they did before. So those are a couple good spots to do that. I know message from law enforcement, you know, if you see something, say something. You know, if you see two vehicles late at night, you know, 4 in the morning, and you get up and get a drink of water, and you know, see two headlights down at the end of the driveway, you know, just give them a call and say, it just seems really strange, you know, or really weird. You know, odds are likely they may be looking for somebody or dealers or things like that, and they can cruise by and check it out and see that. See if anything is going on, and maybe it's not, but you know, at least we'll know and try to prevent that. Important to remember that you know, just because medication is prescribed doesn't mean it's always going to be 100% safe for you. And you know, really make a point of emphasis for looking out for the next generation. Like I said, the earlier kids start with drugs and things like that, the more and more likely that we're going to have problems in the future. So, yeah.
I'm looking at this from the child's standpoint. I work in schools and I see so many kids who are removed from their home because of parents either coming out of jail or because they have an anxiety which turns into addictions. Just looking at the getting out of prison, that percentage just shocked me. What programs do we have that, I mean, and maybe you're not aware of it.
Yeah.
Do we have any programs for them other than here's your parole officer and check in every 2 weeks?
Yeah, that's definitely a social services question. I know, do you know Karen Crabtree?
Yeah.
Okay, she would be a good person to ask. I know I've asked her a couple times about, what is available, what isn't available, that type of thing. And yeah, I think that, that definitely is a weakness, from my perspective too, as to, what can we do?
Sometimes isn't it up to the individual too, sometimes you try to, I have a son that's a drug addict. And how many times that, do you try to, and where do you have the limit?
Yep.
Yeah.
Yep. And I would say, you definitely have to draw a line.
Yeah, I
Where,
mean, yeah.
You make sure you're not endangering yourself and, things like
I
that.
mean, he's not welcome at my house.
Yeah.
I mean, that's a shame, but that's.
Trust me, you're not the only one that's
And
had
I
to
just-
deal with that.
Yeah,
There's
there's a lot of families that, I think probably just about every family has a member that's done drugs. And I have like my other people too that help.
Yeah, definitely not. That's for sure.
Well, I enjoyed this.
Okay,
Thanks,
good.
Eric.
Yeah, no problem.
Thank you,
guys.
Eric.
Thank you much.
You bet.
Thanks, everybody, for coming.
Thank you. Well, I think education is